Ma'am, start.
Yes.
Yeah. Good evening, everyone. On behalf of Maharashtra IAP, I, Dr. Mangai Sinha, warmly welcome all of you to the launch of Maha IAP's Casebook Live. Yes, you heard me right. It's Casebook Live. We have all heard of Facebook Live, but today Maha IAP is launching this innovative way of learning, Casebook Live. So, what is this Casebook Live? I warmly call our president, Dr. Ram Gopal sir, to please explain this concept of Casebook Live to us. Sir, please.
Thank you, Mangai. Good evening, friends. Welcome, everyone. Respected Atanu Badra, sir. Welcome. All the EBs of Central IIP. You are welcome. And today, I welcome our today's expert, Dr. Minaz Sheikh and Dr. Anand Butada, and today's moderator, Dr. Vinayak Patki. Today, we have our again special joining PG students from YCM, Dr. Neha and Dr. Mehreen. A special thanks to Dr. Bhavesh, our scientific convener who has designed this concept, and Dr. Rajesh Kulkarni, Professor YCM, to help in the program. Now, the concept of this casebook live is that there would be an actual case which are handled by the pediatrician. The approach would be discussed, and we will involve the PG students to give their opinion, and after that the experts will give the opinion. So it would be like a PG teaching or a teaching of the practicing pediatrician. Both are kept in mind, and this program was designed. So I hand over to Mangai to start the program and to introduce our guest and our secretary.
Thank you, sir. I think we all are eagerly waiting for this program, and let's see what it unveils and what we learn from it. It's been a wonderful year of planning and many programs. I now call our Secretary General of Maharashtra IAP, Dr. Amol Pawar sir. Sir, welcome, and please say a few words, sir.
Thank you, Mangai ma'am. It has been today's launching program of this Casebook Live, as already you have told and Ram Gopal sir has told. The coordinators for this program are Dr. Vinayak Patki, who happens to be PISO expert, and he is also executive board member of National IIP. And along with him, the Maharashtra executive board member, Dr. Kaustubh Deshmukh, is also there as a coordinator, and Dr. Rajesh Kulkarni sir from Pune, he is also one of the coordinator of this program. So it's like PG teaching only. And I again welcome Dr. Atanu Badra sir, who is the national treasurer. He has another meeting shortly, so he'll be he is there for us and for another 5-10 minutes. So welcome Atanu sir, and he was the past president of past vice president of East Zone, and now currently he has been elected as the first national treasurer of IAP. So welcome Atanu sir, and please address the gathering, sir.
Thank you, Amul. So in terms of IAP academics, what Maharashtra thinks today, the other rest of the country follows. So everyone is I was very eager to know how come, yes, we have heard of Facebook Live, that this is Casebook Live. But I would just allege, Amol, that you should not have put it on the same day as an important meeting. But for this, you have to give a fine that you have to put this recording and see that, and I'll see that it is also sent everywhere. So thanks to our president, Maha IP, Dr. Ram Gopal, Dr. Amol as secretary, the experts, Dr. Minaj and Dr. Anand Butada, and Dr. Vinayak, all very, very close friends of me. And what a professional start of the who said a few words. Madam, you are just professional. I think I need you start these programs everywhere. So start, and I think everyone is looking forward eagerly for this new concept. And hopefully this concept will be refined, and we'll look forward to take it up in Central IIP also and Amol with all the EB members there, I think it would be very convenient for us to follow this idea. Over to the team.
Uh, Thank you so much, sir, for your lovely words of encouragement. It's really an honor to have you with us, sir. Now, without spending much time, I call upon the moderator for today, Dr. Vinayak Patki. Sir is the EB member of Central IIP. He's from Sangli, Maharashtra. He's an excellent clinician and an eminent academician. Over to you, sir, to take this program ahead.
Yes. Thank you very much for the kind introduction. Respected Atanu sir, Ram sir, Amol, and Bhavesh, who has designed this new concept of being case live. And what we are in next 45-50 minutes, what we are going to discuss is this. We are today I am presenting case and I am on moderating the case. So first we'll try to involve the basic problem, whatever the cases are there to the PG students. And then as the case unfolds every time, we'll take opinion from expert. These are the all actual cases. Neither the expert nor the PG student don't know the diagnosis or whatever actual cases. This is the main principle of this presentation, because it is not necessary to reach particular diagnosis. This is to get different concepts, differential diagnosis, and different approach as a PG student and different approach as from experts who are in that field. Every time we'll try to get some different cases related to different system, and next 1 year we are at the first Wednesday we'll try to cover these kind of things. So just without wasting much time, thanks everybody for my team. And without this, it is my duty to introduce my today's expert, Dr. Mina Sheikh. They don't know introduction. They are all known figures, eminent senior pediatric intensivist and head department of pediatrics and neonatology from Lilavati Hospital. And my good friend, Dr. Anand Botada. He is from senior pediatric intensivist from Nagpur. He's now holding the new hospital, New Era Hospital. And my the two PG students are there, Nihar and Amrin. They will be participating. So let's start with the case today. So my screen is visible?
Yes, sir.
Yes,
sir.
And hopefully I'm audible to all. So let's start today's case. This is the first case from 6 March. Today's first thing. That's it itself suggests Casebook Live is uncover the art and science of pediatric medicine. So we have already introduced my faculty, this called experts and PG students. This is case 1. So 10-year-old male child, 41 kg weight, second issue of consensuous marriage. 2 year back, he had history of hyperpigmentation of skin, axilla, neck, groin. And progressively, he is becoming dull and lethargic. Elder sister also had similar complaints 4 years back, gradually worsened over a period of time, and she also died at the age of 10 years. So this child has been investigated. So it was 1 year back, and his cortisol levels comes very low. ACTH was markedly high. His folic acid was done to rule out other hyperpigmentation like megaloblastic anemia. It came normal. Sodium was low and potassium was 5.8. He had also thyroid issue. TSH was high and T3, T4 was low. His abdominal UHG was normal. So he was diagnosed to be a case of Addison's disease with involvement of thyroid, and it was labeled to be a polyendocrine autoimmune disorder. He was on regular treatment and follow, and currently he is on Hyzone, that is hydrocortisone 5 mg TID, fludrocortisone 50 microgram OD, and Eltroxin 25 microgram OD. So he was admitted with complaints of fever with chills on and off and headache for last 8 days and altered mental sensorium. And his blood pressure was 88/60, heart rate was 112, respiratory rate was 24, his CRT was less than 2 seconds. His sugar was 64, it was a random sugar, less than 80. His sodium was 128, potassium was 6.2, chloride was 102, his lactate was 2, urea create was normal, his hemoglobin and platelets were normal. So now these are what we are dealing with here is a case of Addison's disease. He has febrile illness, some sepsis, his hypotension, hyponatremia, and hyperkalemia. So will take first opinion about our PGs. So let's see what they think over this. Yes, Dr. Neha and Mahari.
Yes, sir. So as we know, this is a male child, a known case of Addison's. Currently, he has presented with a febrile illness, that is stress for the body. He is already on treatment with steroids, Fludrocort, and so right now I feel like we should give him stress dose during illness days. We should give him stress dose of steroids.
For the shock part also, sir, we have to now if we go
What do you think? What kind of shock is this?
Sir, could we just see the WBC counts?
Yes, it's
8,500. Lactate is high. So so now we have to think about a septic shock versus adrenal crisis. If it is a catecholamine. So first, I would actually like to go with septic shock first.
So how will you? So we'll come to the experts with this kind of background. Dr. Anand, and first we'll come to Dr. Anand, and next question will go to Dr. So how do you look at this case, and what will be the approach from your side?
So this child with Addison's or basically polyendocrine autoimmune disorder with this background. Now there is a fever, dullness, encephalopathy, and component of hypotensive shock. This electrolytemia is there. So we need to work upon multiple things. So we need to go with ABCDE, our protocol as per the ALS guidelines, and just see the airway, breathing, circulations. That way, if airway and breathing is okay, which looks apparently here, then regarding the shock, look at the fluid status. So this first component, the child who is not accepting orally well, who is known Addison's, so giving and releasing fluid is important. Simultaneously taking cultures, putting 2 IV cannulas, and correction of the electrolyte disturbances which are there. Then simultaneously increasing the dose of steroid here will be important, and giving the first dose of a broad spectrum antibiotic till we get other findings. So here, even though TLC is normal, the child with Addison, polymorphs is high. So I will consider that sepsis can still be an important component. So giving an antibiotic is worthwhile. Meanwhile, managing the component of shock here. And if you have a point of care ultrasound, use this technology, look at the fluid status and the cardiac status.
Thank you, Anand. So with this child has been treated, fluid bolus was given.
Vinayak sir, can we go?
Yes, Minaj.
Can we go back to the previous one?
Yes.
Good evening, friends. It's been pleasure to be over here. Rightly said by Vinayak sir and Anand. We'll go this way. My approach will be like this. Independent of the background, of course, we have to consider the background. That is the case of Addison's disease and all those things. Go to basics. And the basics are very clear. At the first contact, whether it is in ER or ward or ICU, the first contact is 5 vitals. As rightly said, look at the your heart rate, which is little bit on the higher side for this child. The blood pressure, he is in hypotensive shock. Then the work of breathing, RR24 is the higher side. And of course, the CRT is 2 seconds. This is part 1. There's a basic physical examination. So at this point of time, what we will, independent of diagnosis, we'll be making what is called as physiological status of this child as per the past guideline. The physiological state of this child is in hypotensive shock. And as rightly Anand has said, whenever there's a hypotensive shock, independent of etiology, first we make the hypotensive shock to normotensive shock. So we bring the compensated shock to like uncompensated to compensate. So that's first thing. That's number one. Then you have that, these problems in the form of febrile illness, hypotension, hyponatremia, and hyperkalemia. So we are lucky to have these parameters with us, and we'll go simultaneously one by one, as Anand has said. So at this point of time for this particular slide, my approach is optimization of physiological status, independent of the diagnosis. Of course, diagnosis will be on card. So that is from my end for this particular point.
Thank you, Milaj and Anand. So we'll proceed the case as our expert says. We have treated with NS bolus, IV monoseph as first line of antibiotic, and stress dose of hydrocortisone was given. It was treated as Addison's crisis plus part of some sepsis. So sensorium just improved over next 24 hours. BP is better now, 122. Child had started accepting orally within next 24 hours. So then the next hiccup has come. After 2 days, again the child drowsiness has started. He was only responding to verbal commands. He has intermittent headache and irritability. He has fluctuating consciousness with periods of profound disorientation in between. And in other times, he used to be better and responding to mother by verbal commands. He is always complains to be itchy eyes and some photophobia or the whatever in the ICU. He had some difficulty in swallowing, though his oral cavity was normal but bit dry because he was not in nursed properly before him. He had some tongue coating, and he had some enlarged submandibular glands. And intermittently, he had a abnormal limb movements. Just he was throwing. There was not at all a convulsion at this point of view. So now coming to discussion. So this is a case of Addison's disease with hypothyroidism. This Addison's crisis has been treated, and now he has, after 2 days, he has developed some altered sensorium and abnormal behavior. Now, PGs, what is your opinion, and how will you approach this case? Yes.
So first we'll like to rule out if there are any electrolyte abnormalities like hyponatremia, or if this is a worsening of sepsis which can meningitis, which could have led to raised ICP also.
Okay. Any other possibilities what you are thinking? Yes, one is metabolic. Yes, you are correct. Other one is sepsis part. That is also correct. Any else broad in other broad spectrum? What anything you want to discuss? He has also case of hypothyroidism.
Thyroid crisis.
So endocrinal cause.
Yes.
Yes, yes. So what will be your approach? How you are going to approach this case?
So first, if there's dyselectrolytemia, we would like again, sir, we'll start with airway breathing circulation and propped up position.
Vital parameters we like to see for the
from history, anything you are getting this abnormal movement, anything any pointers you get from the history and clinical examination?
Behavior.
Yes, all this can be part manifestation of all these things. Okay, now we'll shift to our expert. First, we'll go to Anand and then we'll go to Minaj. Yes, Dr. Anand.
Okay, so now this child who had come basically with hypotensive shock, dyselectrolytemia, after we have corrected all these things and we have optimized the doses, again, this child had a fresh deterioration in the form of disorientation, abnormal behavior, dystonia, difficulty in swallowing. So there can be multiple reasons for that, and we need to look at all those things. First, whether the primary disease has worsened, the sugars are low, or the sodium has again fallen down, or there is other electrolyte abnormalities like hypocalcemia, hypomagnesemia over here. So I would like to send all these investigations. I will like to look at the vital parameters, whether the component of shock has again appeared, even if the BP is normal. So I will clinically as well as workup wise, I will like to go ahead with that. The third again is the endocrine issues. So other than Addison, whether the thyroid is causing any issues. Fourth, the child had probable sepsis. So he is developing the CNS manifestations. So is there component of meningitis or encephalitis? So CNS infection can be another possibility over here. Then having a history of any toxin consumption, especially looking at any drug overdosing or underdosing over here, that is again important component. That gives interesting history of difficulty in swallowing. So so is there any history of animal bite? Why this is a change in behavior, sensorium? So any recent history of animal bite? So rabies can be an important thought process over here. So I will look at all these components to work up. And meanwhile, I will continue with my management and look at any subclinical seizures. So we'll get one EEG done. Will like to trace the blood culture that was sent earlier. Like to repeat the sepsis parameters like CBC, CRP, PCTs if it is available.
Minash, your views?
Well, I agree what Anand has said, except my approach will make it very simple. This is day 2. The child was stabilized to begin with, and then new onset symptoms. So the first thing in ward and ICU that we do is we look at what any intervention has changed all these things. The first thing is introspecting ourselves. Any medication or any intervention that we have done has changed the course of illness. That is number one. Having ruled out that, whether it is medications or other interventions, which is not the cause of this, I will set my house set right like approach to a case of encephalopathy. And then we'll go as Anand has rightly said. So this is the way I will go ahead.
Okay. This child has been investigated. Metabolic workup comes almost, say now all repeated, we have done the investigations. Yes. So here metabolic things has been ruled out. Potassium CBC is normal. Blood pressure is all normal. Sugars are normal. Urea creat is normal. So we have done here just for 2 things we did. One additional thing, as all of you are suggesting about some kind of encephalitis or meningitis. We did CT brain with contrast, surprisingly came normal. And CSF actually was done, but this child was not able to get sedated properly, and CSF got unfortunately traumatic with 80 RBCs, 8 to 10 cells, 60%, 67% cells were there, and 90% lymphos, protein mildly elevated, sugar 80. So keeping all this mind, with the sepsis part has been corrected, metabolic part has been corrected, some kind of traumatic CSF, but CT normal. So we consider some kind of a encephalitis kind of thing. And as we know, this is a altered sensorium. So monoseph, vanco, and acyclovir was started for this child. So just to highlight, this is the child. This is, you can see the hyperpigmentation of this child in the nape of neck, axilla. This is a bit obese. This has been put, line has been put, center line has been put. He was on DT feeds. And just I will show the video. It has been masked, but could not able to mask totally. So this how he used to do intermittent. So this used to be his behavior. Then we'll go to next thing. So on day 3, GC is slightly better. He was intermittently drowsy. So after starting some basic things, and with that also, yes, we have added 3% normal saline and 1 dose of mannitol was given. No fever spikes was there. He was stable on room air. He was tolerating some sips of water. Neurophysician said same thing, maybe query meningitis, query encephalitis. And he said to continue on same line. He said if child condition deteriorates, we'll get one EEG. And he said if general condition doesn't, general condition again deteriorates, we'll plan for repeat CSF, because it was done almost, because we can't repeat CSF after maybe within 40 hours. That was the thing. So we thought we have come across, we have tied the crisis, and just we continued. So day 4 GCS remains same. He had now complaining of some headache intermittently, some itching eyes, and he was complaining. But in that kind of sensorium, we could not able to pursue that how much significance to give to that headache. He was accepting some liquids now orally in spite of DT was there. In between, he was crying for some liquids and all. So day 5, something different has happened. His irrelevant talk has increased, his aggression has increased, and in that aggression, it was followed by generalized tonic-clonic seizure. As protocol, we have given lorazepam, but not controlled, so required levetiracetam and phenytoin. So these boluses were given. His breathing was shallow, though he was maintaining saturation. His GCS was going around 8, and then desaturation he started with gasping respiration. So we have intubated this child, and with number 86, and we have put on pressure control mode of ventilation with very minimal settings 25. During this, just after intubation with this minimal setting, his saturation became 96, blood pressure was normal, and heart rate was 96. So this is the post-intubation X-ray, and this is the video. This is here. He's not been any under sedation. This was done after 8 hours. So this some kind of there was no generalized seizure, center line in situ. If you see this heart rate, respiratory rate, blood pressure looks normal. ET tube in place, also DT also in place. So now we'll come to new why this GCS has deteriorated. What is the new onset seizure? Why patient has developed, and how we are going to approach. Well, first we'll go to Neha and Amarin for their approach at this stage, and then we'll go to experts.
Sir, like we have actually kind of ruled out the dyselectrolytemia and the sepsis part. So since he has a history of immune dysregulation, so this could also be an immune mediated problem. New onset autoimmune encephalitis. And secondly, when the child was stable taking sips of water, room air, I would have preferred an MRI over a CT brain. And second, headache is along with altered behavior, so red flag signs are present. So we need to investigate this further. And
how will you go for in next investigation?
So autoimmune workup, sir, I would like to.
Is it going to help immediately? What will be your priority in this case?
Priority will be to stabilize the patient. And the kind of respiration he had gasping, this could be due to the CNS cause, because as we saw the X-ray, there were no respiratory causes of the gasping respiration. So either cortex or the bulbar involvement could be there. So
yes. So we have intubated this child.
We have intubated. So we control.
What are your next plan? In the part for
seizure, I would like to do a bedside EEG also, sir, to see because if it is the kind of seizure and if it is a non-convulsive status epilepticus, if it is like that.
Yes.
Because if my drugs are convulsing, then.
When you want to shift this child for imaging, what is your take on this? You said something related to MRI.
Yes,
you want this child to be shifted immediately for MRI?
Not now, sir. No, not now. MRI will take longer time. So
yes.
But not now. When in the intermittent he was stable on room air, I would have done an MRI. But now he is deteriorated. So first priority is to stabilize the patient and control the seizures. We don't know the new onset seizures, the kind of seizures which are happening, because we saw the GCS without sedation. Also, the child is unresponsive.
Okay.
Bedside EEG, I would like to do.
Okay. Now we'll go to first Anand and then we'll go to Dr. Yes, Anand.
So very well pointed by both of the residents, Dr. Neha and Dr. Marine. So there is another deterioration, but then this deterioration, rather than sudden, it was always giving a clue that this child is not perfectly okay. So there were fluctuations in this course. There were headache, some improvement as far as the sepsis parameters, fever, electrolytes were there, and the perfusion was there. But then the other way around, the CNS symptoms were present. So something was not getting correct. And as there were seizures here, so it actually worsened the child immediately. So the priority is always to manage the airway, breathing, circulation. So that way, doing an intubation and using RSI. So it must be rapid sequence intubation always. And meanwhile, you need to work up for the cause. So once you have intubated, control the convulsions, manage the features of raised ICP over here. So 3% NS infusion or mannitol, whatsoever is the protocol of particular unit. We particularly use 3% NS over in this situation. So first do this. Once again, check the blood sugar. The child is with the Addison's disease. So if there is hypoglycemia, control that and check the electrolytes once again here. And if they are not normal, so correct it. So after doing that, here autoimmune looks higher on the cards because there are fluctuations and there is a setting for autoimmune disorder, and the previously CT brain is apparently normal. The first CSF unfortunately is traumatic, but then that happens many a times. So as far as workup, as rightly pointed out, if we would have got an opportunity, we would have preferred to get an MRI brain earlier. Now, once this deterioration is there, so better to get one MRI brain after the child is completely stabilized. So wait for few hours, let the seizure settle down, let the child be hemodynamically stable, and the team is ready to go for a MRI brain, counsel the relatives. And meanwhile, you can do some bedside investigations like an EEG. If there's a 48 hours gap from the first CSF, I will like to repeat the CSF after getting a neuroimaging done. And this time in the CSF, I will, apart from the routine microscopy and cultures, I will like to again add the panel for.
Yes, sir. We'll come to that part later. Yeah. Minaj, any of different views from your side?
Yeah, go back to the previous slide. Again, go previous, sir. Okay, this is very interesting. A child with us on day 4, day 5, again deterioration. What's important is two things, apart from what Anand has said. A child who is with us, a neuromonitoring. The hourly neuromonitoring should be in place, including GCS monitor. So this is number one. So when the child is there, the monitoring and intervention and again reassessment. That's number one. Done properly. Then there's a the one learning point is that desaturation with gasping respiration. So we should know at what point of time we should intubate. So it's very clear. Any GCS 8 or below, number one, and number two, drop of GCS by 3 from the baseline. Suppose I have a child whose GCS has been 14 and has dropped to 11 or 10, I think I have to intubate this child even if the GCS is around 10 and 11. That's number one learning point over here. Number two, once we feel that it is a case of neurology, the entire bundle of neurocritical care is in place from word go. And that neurocritical care bundle includes tier 1, tier 2, tier 3 therapy. Here we will be tier 1 therapy. That includes your nursing the child in a quiet environment, avoiding all kinds of non-noxious stimuli, and then keeping the child in 30 degree elevated and no fever, normoxia, normocapnia, normal sodium, normal sugar. So all those things will run side by side all together in this particular child. And then, as rightly said by our two students plus Anand, we will go for the investigations. This is my
So this child has, we have done bedside EEG. Some spikes were there, but it was not a status. Metabolic workup was normal. Sepsis screen was negative. Electrolytes were within normal limit. So, so what we thought initially, this is a generalized process and not a pupils equally reacting and all. So what we initially actually went for a repeat CSF, and as general condition has improved and other things. And this is the CSF. Now comment from PG students first, and then we'll go to expert on this. Since proteins have raised, glucose normal, glucose low, in fact.
Low. Corresponding yes.
Yes, WBC is 200. Simultaneously, sugar was 84 for this 84. Child. 200 cells, 65 WBCs, 65% neutrals, 35 lymph nodes. What is your comment on this? Child is on now monosif, vanco, and acyclovir.
It is suggestive of some inflammatory pathology.
Yes,
so
it is there.
Empirical antibiotic.
It is there inside. Down it is mentioned inflammatory.
Yes.
What do you think? It
It is
is
not working.
Not,
Not working. Our treatment is not working.
antibiotics,
Are not-
empirical
are
antibiotic
not
therapy hasn't worked. So,
so. Do you think this is a pyogenic meningitis?
no.
No.
Why no?
84 and sugars were
Sugar
protein.
would have been lesser.
Would
and
have been lesser
protein.
than 130.
Could it be tuberculous meningitis?
Can be.
Could it be encephalitis?
But cells are actually
Cell counts will be higher, sir.
Can you get any clue from this? Any conclusion can you come to conclusion about this CSF? First was traumatic. This has come. Child sensorium is deteriorated.
dislodgement or of a richest focus or any hydrocephalus.
Okay, okay. We'll go to experts now. Let's see what they feel. Yes, Anand.
So this is showing basically leukocytes with polymorph, slightly predominant, high proteins, low sugar, and this can be seen with meningitis. So the child is on treatment already, can be seen with partially treated meningitis, can also be seen with atypical infections like encephalitis, tuberculosis. In an immunocompromised child, it can also be seen with the atypical organisms as well as the fungal infections over here. And it still there is a possibility that it can be an autoimmune encephalitis. So
Minaj, what is your take?
Well, this particular set of information have to be taken with, very cautiously.
Yes.
It may not give a single diagnosis. It only says that there is some inflammatory process which is going on. We have to take in totality. So CSF gives the direction, but not the confirmation.
Okay. We'll go ahead.
This much information is not sufficient.
So we did. Then we go for MRI, as all of you were agreed. And this kind of MRI, where this is a T1 things. Multiple small diffuse scattered areas of altered signal intensity, which hyperintense on flare immediately on almost frontal, parietal, occipital. All white matter has been involved. And this is the parent patchy meningeal enhancement was there. So which is there in bilateral, frontal, parietal, and temporal. I will show more images so that you can understand in a better way. So this is a coronal section. This first was axial. Almost you can see how it is so diffusely has been involved, and white matter almost frontal, parietal, occipital white matter has been markedly involved. And this is a flare T2. You can see again it is a very classical picture of white matter hyperdensities are there on T2. And this is a diffusion image. You can see the characteristic diffusion image is many of these lesions have a restricted diffusion. This is something very much important. And there was no enhancement. So what they thought about is, you have to see clinically, you have to correlate. But this kind of white matter involvement, diffuse involvement, so they also thought about autoimmune meningoencephalitis. So that was the question here. Now, yes, we are plus minus. Some pointers from history are there. CSF not conclusive. Now, how we are going to go for it? So here what we thought raised proteins, lymphocytic pleocytosis, and suggestive of autoimmune encephalitis. So how we are going for investigations and how we are going to manage. First PGs and then we'll go to experts. Yes?
So for confirming autoimmune encephalitis,
So what will your priority? Confirming autoimmune encephalitis or treating other?
Management
will be first.
Yes.
So we
Role of steroids.
Steroids.
Which steroid you want to give? Hydrocortisone, dexamethasone, methylprednisolone.
So for this patient,
MDS will be.
Okay. Anything? Did you come across during your PG?
We just had a viral mumps encephalitis patient.
Okay. Yes.
Responded to MDS.
Okay. Anything in your mind at this stage? How we are proceeding? Just before proceeding next to going to
So for
explain what-
autoimmune encephalitis, for the child in this condition, we can also consider, apart from steroids, we can consider either plasma pheresis also, or else followed by IVIG, and then we can give pulse doses of methylprednisolone followed by maintenance doses when the child starts improving.
Okay, so these options you want to get. And any other investigations? Yes, we'll then we'll go to it.
The
Then we'll go to it.
investigations, we would like to send autoimmune panel for CSF, all the antibodies.
And
Okay.
Cox workup also, I would not like to miss out Cox workup.
Okay. Okay. What do you want to don't want to miss?
Tuberculosis,
For
Tuberculosis.
which is right.
Okay.
Which
Okay.
is right.
So Anand, as an expert now, you tell how will you manage? How will you see at this case now? We have seen now from Addison's crisis to now autoimmune encephalitis. This is
Yeah. So it's pointing more with that sort of a neuroimaging towards autoimmune phenomenon, and the background is there. CSF was not pointing towards a particular disorder. So here I will first will start the management with the IV methylprednisolone after talking to the relatives, and IVIG can be an important option or can be a simultaneous treatment. Second thing, will to continue stabilizing the child with ventilation, fluids, electrolytes management, and endocrine management. Third, involving a multidisciplinary system now. So we'll involve a pediatric neurologist, an ID expert over here, and a rheumatologist over here. So we'll take an opinion from my colleagues from different specialty, and we'll send the investigations over here. So CSF autoimmune panel, CSF culture, and the PCR panel for the atypical infections of CNS, obviously. So biovirus has to be sent. So all these investigations. Apart from that, the from blood, obviously ANA should be at least one that I should be sending.
Vinaj, what is
I'll
your
go
take?
back to previous slide, sir. So I have a couple of thoughts at this point of time. Though our focus is more towards autoimmune encephalitis, but I would like to go and rule out acute febrile encephalopathy. We are a tropical country, so we have to rule out that also. It's okay. We are having a febrile encephalopathy and autoimmune encephalitis, but all those things, acute bacterial meningitis, partial treated bacterial meningitis, tubercular meningitis, enteric encephalitis, of course, it is a short duration history and all those things, and other infections that have to be ruled out. So tropical encephalopathy has to be ruled out. That's number one. Number two, because we have to, if you go by this, our Government of India guideline, there's a clear-cut guideline for febrile encephalopathy diagnosis and management. So this is the step one. Step two, with regard to this particular MRI, what is conspicuous is that it is not very specific to particular types of encephalitis. Say, for example, we have HSV encephalitis. So we know what part of the brain is involved. So that particular specific affiliation is not been there in particular this MRI, except that it is a diffuse involvement. So that another thing. So that those specific encephalitis syndromes have been ruled out by MRI at this point of time. So this is the take at my at this point of view.
Okay. Thank you for both.
Here I would like to comment this MRI,
Yes.
the vertical hyperintense lesion, which is diffuse, not having a particular syndromic pattern. This is very, very typical of autoimmune.
Encephalitis, autoimmune encephalitis. I agree with you. But then, yes.
Yes.
Sir, and should be two questions. One
Yes.
So based on MRI findings and CSF findings, so why can't this be Adam, sir, acute demyelinating lesion? Because he also has eye redness, eye itching also.
Yes.
So how can we
This Adam involvement is actually paraventricular involvement most of the times, and such a diffuse involvement with patchy meningitis, patchy
meningitis.
This is not there in Adam, so that's why we should.
So second thing, should we do we would like to do a serostatus also to consider fungal also and
Yes.
lower down, but serostatus and fungal should not be missed.
Okay.
Because these are steroids. And
So, okay, I take took your point, and we went with this. We went
So,
with IV gamma. Patient
Dr.
has not.
Patki, if
Yes.
Dr. Patki can give me a minute just to ask few questions that
Yes.
what is the status of the fever of this child? Is this child still running fever? We are on day 10
No,
probably of a
no fever.
management.
No fever. After that, no fever. Absolutely.
So,
Bhavesh sir, probably this child may not have the fever because he is on background steroid for his disease.
So if we understand this child before admission had a fever and headache, abnormal behavioral for almost 8 days. After admission, the child continued to get fever roughly for 3 or 4 days.
Only
And
for 1 day, sir. Yes.
Only
yes.
for 1 day. So
One
total
day.
duration of fever is roughly around 9 days. Beyond that, child never
That
had.
fever also was not a continuous. In between fever spikes were there. So no, it was not.
So clinically, this also kind of rules out that are we not dealing with an infection, because this
Yes.
child is not on a NDTB therapy. This
Yes.
child never had a very focused suggestion of a meningitis. I mean, why a 10-year-old child, 41 kg, should have a meningitis unless there is an immunocompromised state?
Yes. Yes.
So everything is kind of a favoring away from the infection. I mean, overall, if you understand the process.
I agree. So we kept the possibility of autoimmune encephalitis, which was clinically correlating and other.
Bhavesh sir, my idea was bringing up febrile encephalopathy is that, we should not be like straightway first step in our part of the world, fever, even subtle fever with altered sensorium, we have to rule out CNS infection.
Yes,
that's very clear. Then the next step, having ruled out the infection, because that is very much treatable. Early infection ruling out, early treatment, very good outcome.
Okay.
It can be anything. I do agree. 10 years, 41 kg child should not have infection like ABM, but we have to rule out the febrile encephalopathy. Yes. Having ruled out that, then we can proceed for these kind of infective or inflammatory disorders. That was my thought process.
I agree, because this was the whole thought process went in our mind also when we actually managed this case. So plasmapheresis, they have rejected. So what options remains with us with IV gamma and pulse methylprednisolone? So we are given, and we have sent samples for different things: CSF biofire, CSF autoimmune panel, and ANA panel. Let's see what the investigation says. So this came within 24 hours. So all our infective etiology has been ruled out. So including Cryptococcus neoformis has been ruled out, and all CMA and other infections have been. Next thing, this took time. About autoimmune panel. Autoimmune panel came negative. So autoimmune workup has this week they could able to do. Right now available tests are only these 6 panels are there, which they could able to do. Then next thing, day 7, one episode of again desaturation on ventilator, but here there was no convulsion. SpO2 dropped at 65 to 70%. Very thick secretions were there. We could able to do the suction after soda bicarb. We could able to suck those secretions. That came 96 to 97%. PCU mode slowly shifted to SIMV mode. Other things were just continued. Day 7, this came surprise. Here urea was raised 45, create raised, SGPT, SGUT mild elevation was there, but no bilirubin was raised. Here protein 6.3, 2.8, 3.5. So AG ratio was reversed. Though ProTime was normal. APTT was normal. CBC this was not 23,000. This is a typo mistake. It is 2,30,000. Sugar was 78. Sodium 130, potassium 3.9. Comments. Now comments from PGs first.
Sir, Vinayak sir.
Yes.
Before we take up this particular slide, can we go to the previous slide, please?
Yes, sure.
Yeah, sorry. Both of you, dear, our students, what would be a child on ventilator having desaturation? What will be your first step or approach?
We would like to rule out dope, sir.
Excellent.
Displacement, obstruction, pneumothorax, and equipment failure.
So what dope means? Please one at a time. Displacement,
obstruction, pneumothorax, equipment failure.
Perfect. And in this particular case, probably as sir is checking, what would have been the cause?
Obstruction, because on
Obstruction of
suction
the
it has improved.
Excellent. So this is, it's not that we go and increase the FiO2. That's important. We have
What
to,
about now PG's first? What about this take on investigations?
yeah, now they're coming to this. Yeah.
RFTs have worsened, the SGOT-PT has raised. This means that there's a multi-system involvement right now. And what's
Dr. Anand?
Yeah. So in this scenario, as the days are progressing, and the secretions have got worsened over there, they were thick. So we need to consider many points. One of the things that they thought that the disease process is worsening and now there is multi-organ involvement, but there can be other aspects as well. So we need to look at any hospital-acquired infection or new infection, especially on the child on steroids, intubated with lines. Second thing is the medications which are going is proper or that's causing any toxicity. Then another point will be if the child is underhydrated, so need to check the fluid status properly and taking care of the perfusion over there. And is there any new onset sepsis, which probably is hospital acquired? So all those points we need to consider apart from the ongoing disease process which has worsened.
Dr. Minash?
Yeah, now we are going for the MODS, subtle, because you have an AKI. Creat is 1.4. So 1.4 creat is, you as per the KDIGO criteria with the urine output, you have to take into account, am I in the AKI? So creat is 1.4, whether it may be pre-renal, renal, we don't know. For fluid status, we don't know. So that's about with regard to kidney status. OTPT is changing. You have reversal of AG ratio. So we have to look into what is actually happening over there. You have mildly deranged, not very significant, INR of 1.3. Yeah, and important thing is always in a neurology case, keep the sodium above 140. Here the sodium is 130.
Yes.
So you have to see, you have to see why there is actually drop in sodium. You have to look at why the sodium is dropped, whether the delivery is restricted or whether there is other reasons to account for that. Or you have a background Addison disease over there, right? Already has been there. So this you have to keep in account. So, and then what is the cause? As has been said, either new onset sepsis that we have to take into, because the counts are also increasing, 23,000 counts, right? And need not be this count is because of infection also. You have the stress in place and you have the steroids in place. So you have to also take those increased count with the pinch of, with salt. But of course, sepsis is always on card. Yes, sir.
So this is something what we are till now we have come. So this is Addison's with hypothyroidism under control, autoimmune encephalitis under treatment. He has developed some altered LFT and RFT. And now
go back to please, sir. So I will have a comment on hypothyroid. This can be a sick thyroid. So a status of thyroidism has to be taken after the disease has been taken care of.
Exactly.
So
this is a very important point you raised. Correct.
So this thyroid, I will take a pinch of salt. I will, once the things are stabilized, then again revisit for thyroid status. So this is sick thyroid.
So now let's see, patient extubated after CPAP trial on day 8 was put on nasal prongs. His sensorium was better, 5 plus 3 plus is it 12. Now he has developed 2 fever spikes. Procal blood culture was sent, CBC, CRP and urine routine micro was sent. On day 9, patient has become tachypneic with saturation of 91. But there is no fever now. And what we thought this was in decreased air entry on right side. So what is this? It's been written. This is something very interesting has developed. He has developed spontaneous pneumothorax. So this was actually after 24 hours of extubation. So here with what I want to ask first, PG, is if you get this kind of spontaneous pneumothorax, what will be your approach? Whether you will do needle thoracocentesis, you will put tube, what you are going to do?
So we'll do a needle thoracocentesis, and if the saturation and breathing improves, then there is, if the pneumothorax is drained, then we don't need to insert ICD. But if it isn't and it is progressive, then we'll insert an ICD. So,
So,
and depending on his vitals, also heart rate, if no.
okay, just Anand, quick points from you. Why this child? What can be the possibilities in this background now to develop spontaneous pneumothorax once the child has been extubated? Just quick comment from one you and one from Minaj, and then we'll proceed.
So look at this X-ray particular. Apart from right pneumothorax and underlying collapse, the heart is shifted to the same side of pneumothorax. And if you carefully look at the trachea is still getting pulled to the right side. So I think so the primary problem still can be thick mucus secretion that you pointed out earlier, and that needs to be taken care. So there is a collapse on right side and spontaneous pneumo or during extubation or a significant coughing whatsoever has caused pneumothorax, or maybe an underlying development of a new onset hospital acquired infection like a VAP. That can also be a possibility. So we need to look at all those points. Of course, going for a needle thoracocentesis at this point is justified, as well as ICD placement.
Minaj, primary, secondary lung involvement with whatever systemic disorder. Just quick comment from you. Whether it is possible at this stage to throw spontaneous pneumothorax.
Spontaneous pneumothorax, before that I have a point that, something called extubation readiness.
Yes.
So, get an X-ray test before we extubate the child. Whether this pneumo was setting in before or that's number one.
That was normal. That was normal.
Yeah, that's one normal. So this is something which has occurred afterwards. But second point is pneumothorax. Don't get ghabrane ka nahi if pneumothorax is there, because there's something called as tension pneumothorax versus non-tension pneumothorax.
Non-tension.
If you don't have a tension pneumothorax, you have a time. And what we do with needle thoracotomy is you make a tension to non-tension pneumothorax. That's number. And then the next, Vinayak sir, your question with regard to what is the secondary causes of all this involvement. We have this child who has, thick secretions, itchy eyes, photophobia. I don't know what is happening to this. The secretions have been thick from the beginning.
Yes.
So we have to take into account why this is happening. I don't know at this point of time.
So now 1 fever spike, O2 5 liters, because we have kept this urine output was okay. And the right side air entry is now decreased. Now pneumo is drained, but this is how the X-ray looks like. So now comment from PGs first, and then we'll go to experts.
Expansion, pulmonary edema.
So PG first, have a look on the monitor. What are the findings in the monitor, and then what are the findings on the X-ray?
Monitor.
There is no tachycardia, saturation is 99.
99.
No tachypnea. Maybe mild tachypnea.
Mild tachypnea is present.
So mild tachypnea, mild tachycardia, did in 15. Okay, so something is cooking over there. Yeah, and the blood pressure is okay, 110/72.
Re-expansion. Collapse is there.
What is there?
Can you read the X-ray? Small X-ray reading.
Can it be? What do you think?
So is it a collapse?
Yes.
It's a collapse.
And
yes.
And the
collapse on which side, beta?
Shifted to the same side.
So collapse on which side? Which lung has collapsed?
Right.
Right. Full lung?
No, sir. Not full lung.
Okay.
So and also, so there was no ICD placement done, right?
Because
if there is a
no ICD.
pulmonary edema,
Can you see? Do you see ICD here? No.
No, not in this, sir.
Yes. Yes. Quick comment from Anand and Minaj, then we'll proceed.
Yeah, so we can see clearly the collapse, shift of the cardiac shadow to the right side, pulling of the trachea to the right side, and upper lung, some shadow is there. Not sure completely pneumo is drained or not. Can't see on this particular X-ray air bronchogram very well, but there is definitely collapse. With the history of thick secretions earlier, also spontaneous pneumo, I will like to subject this child to a bronchoscopy, and if I can find the thick mucus, will drain out. Very rightly pointed by Minaj sir, why this child is having so much of thick secretions. Is it because of infection? Intermittent fever spikes are there. So is there any hospital acquired infection? Subject that mucus to the basically microbiological examination and the cultures.
Yes, Minash, your expert comment.
So apart from what has been said is look at the left lung. It's hyper expand. So complete, intercostal spaces have increased. The total lung expansion is more. That's another thing which I would like to add apart from what has been told. Yeah, next. And I agree for going for bronchoscopic bronching this child.
Yes. So check bronchoscopy was planned, mucus was removal. Again, very thick secretions. It was sitting in the right main bronchus. And also there was, as Minaj pointed out, there was some blockage on the left main also, which also was drained, maybe which was causing ball wall kind of mechanism. And there was hyper expansion of the...
Hyper expansion.
Yes. Then chest physio started, postural drainage was started, O2 tapered, vitals maintained on room air, RT fit started, investigations repeated, almost same, nothing has been there. And you can see the X-ray now on second day after chest physio. So day 12, he was maybe after 2 days, his general condition was better. He was discharged on solumedrol, levetiracetam, toricort, eltroxin, and ambroxol. He was discharged with Ryle's tube in situ and urinary catheter in situ. Chest physiotherapy was, we asked him to continue. Let's see what is the follow-up of this child. 21 days, his catheter was we could able to remove. 35 days, nasogastric tube was removed. 42 days, he started walking with support, almost normal activity. And now solumedrol is tapered. Then the surprise has come here. And this was the ANA what Anand was asking from beginning. This ANA has come. And ANA come very strong positive 85, RO 52 KD. This is called as ANA blot test. Almost 18 antigens are being tested. And this has come like autoimmune Sjogren's syndrome. So if you just thing which was not fitting in the picture from the beginning, itchy eyes, submandibular glands, thick secretions, not able to swallow the things, autoimmune CNS involvement, and this we could able to see now it is a Sjogren's syndrome. And then we started looking after this. So this was a primary autoimmune Sjogren's syndrome with autoimmune encephalitis. And then, so these whole things can be explained now. Dryness, difficulty, everything can be explained now. Parotid submandibular gland was also involved, and we have started giving adequate hydration. And luckily, this day before yesterday only I saw this child is walking now. Parents are very happy. And I have not seen autoimmune encephalitis child coming to walking to me. This may be the first or second case which I am seeing. Most of the times they have status epilepticus and comorbid condition. When actually, to be very frank, when I discharge this child on renal tube or RT, and when we discharge on catheter in situ, we are given very guarded prognosis for this child. So this is something about, but autoimmune panel came negative. Then now quickly for last 5 minutes, we'll go through what is the literature says about this. And this was a review of laboratory diagnosis on autoimmune encephalitis. And they say that only we could able to diagnose 5 to 6 panels. There are a lot of things, and 50% of the cases, and this I discussed with 2-3 eminent pediatric neurologists also. And they also agreed that most of the times their autoimmune panel comes negative. So don't go only on autoimmune panel negative, still can be autoimmune encephalitis. See, this is how the various diagnostic approach, what they say. See here, clues they have mentioned. This is a very interesting table I could get from. This is, they said, syndrome based criteria. Then early, what is the advantage is early immunotherapy you can use, inclusion criteria and studies. And what is disadvantage is incorrect, not helpful for differential diagnosis, and can lead to over immunotherapy. If you see response to immunotherapy useful in retrospective case analysis, but per se it is not useful as an initial decision. And last point is very important. This is clinician's gut feeling based on clinical course, MRI and CSF test and antibody test. This is a case-specific approach which is confirmatory and determines the comorbidity, tumor and long-term treatments. Though it may be sometimes requires experience, can be sometimes incorrect, and sometimes false positive and asymptomatic autoantibodies are there. Then we have gone through the literature, and what it forms is limbic encephalitis is a heralding manifestation of primary Sjogren's syndrome. And if you can see this involvement of hippocampal, bilateral temporal medial lobe is there. And autoimmune here, if you this case, this also autoimmune panel and paraneoplastic antibodies were negative in this published case also, and this has also alternating alternating sensorium manifestations was there. Another important article what I could able to get from 2021. This is encephalopathy is a unique manifestation of Sjogren's syndrome and expanding the spectrum of steroid responsive encephalopathy. They respond very good to the steroid, and that's why this case of autoimmune encephalitis has responded very well to the steroids. So then I will stop sharing. I will ask, this is I think 10:10. Maybe it's just I'm not able to see.
Yeah.
10:8. I will take over to Ram sir. I think this is enough discussion now. I think second case, it can go again for 45 minutes, but I think we'll stop here.
I think we'll stop here. We'll take next time.
45 minutes. Just before closing, sir, I will take two comments from first from Anand sir and next from Minaj sir, and then we'll switch over to you. Yes, Dr. Anand, this is.
Yeah, this is a fantastic. It looked like we are watching some thriller show, and at the end, the culprit was something different. So it looked like an autoimmune encephalitis, but Sjogren, and giving the clue all the time in between to us, we were missing the enlargement of some mandibular gland, thick secretions, collapses of lungs. So we need to keep our wide open, and still the clinical examination and experience counts, and long-term follow-up counts. That's an important thing. One more message, I think so during discussion we missed to check the sero status of the child. So HIV
was negative.
Discussed that it is positive or negative. And must be a thrilling experience for Vinayak sir. And we felt that we are again residents, clueless what questions are going to come. Luckily, both Dr. Marian and Dr. Neha were the opening batsmen over here. So we came one down like Kohli. So that helped us.
Minaj bhai, aapka opinion expert.
Well, I have a couple of acknowledgements and the thanks. Number one is the name itself, the casebook lie. I don't know who has thought of this. Very interesting. Very tempting.
This is concept from Bhavesh and Ram.
That's number one, the casebook lie. Number two, I must congratulate the MahaIP team for coming up this concept. Ram Gopal bhai, Amul, and Bhavesh are also. Next is students. I must tell, coming to the webinar, not knowing the case and doing exceptionally well, I think we must compliment them.
Yes.
So both of them have done very well, and their mentors, Rajesh. Rajesh has been excellent academician. Probably this reflects the way he's training the students.
Exactly.
And the last is the case itself, because making a case and not only for the academic point of view, but actually treating on in the ward and the ICU and giving good outcome. For this, I think Vinayak needs a lot of applause. Very good case, and I think it was a good beginning to the casebook lie. Thank you for considering us for this particular day. Thanks a lot.
Now we'll come to Rajesh sir, his mentor, because students have already spoken and they look quite happy faces. Just before going to Rajesh, we'll take one comment line from PGs, and then we'll come to Rajesh sir. Yes. How did you feel this case, Neha? And yes, please, one point from one line from you. Yes, please talk.
So we joined this webinar thing, not knowing what it will be. Something might, sir had said that it will be something related to our PIC, whatever we see every day, but this was something that we didn't expect, but it was a nice, good experience. So
it felt like we were in the PICU and
the
labs, the videos. It was such an amazing presentation. It was very thrilling. We were on the edge of our seats, sir.
So we wanted the second case.
We wanted the second. We were like, we want one more case, sir.
Because now we got a hang of.
We are getting that we should see. We should not go too focused in the tunnel vision. We have a bird's eye view.
Thank you, Rajesh sir. Aapka point now. He is a mentor, and we very congratulate both PG students and as well as you, because this is something surprise came and they have tackled it very nicely. Your comment, sir. One or two lines.
So amazing format, I must say. Whoever thought of this format, kudos to them. I think Vinayak sir, you and Ram Gopal for naming it aptly. And second thing, I think this is a very good format because here both postgraduate students and the practicing pediatricians both are there. I think it seldom happens. Usually either it is for postgraduates or it is for practicing pediatricians.
Yes.
And I think this very unique idea of having opening batsmen as PGs and then letting the master blasters come is very unique and very great idea, I would say. And I'm very happy that my students have performed well. And I think all the credit goes to them for being so, they were witty and they could answer the questions. Thank you very much.
Bhavesh, are you there on the? Are you online?
Yeah,
Yes,
Yeah,
Bhavesh.
Bhavesh is there. Bhavesh, unmute.
Bhavesh, please your comment now.
Yeah, I mean, it's an excellent interaction between all the experts as well as the moderator who himself is an expert, and of course the PG students and the mentor Dr. Rajesh Kulkarni. Whatever we had envisaged, I think has really worked well in the first launch itself, and I wish that each and every webinar on this Casebook Live should have a more and more participants from all the medical institute, medical departments of various medical colleges across Maharashtra and beyond. And it will be really interesting to different view from the different PGs and the practicing pediatricians. And really, the case was very interesting. And I must say that you have loads of the case in your so-called cupboard. We will dig out each and every case throughout this year.
Yes.
And we will have a case
take out
book
our we'll take out our khajina one by one so that things will improve, help everyone.
And interestingly, in this particular case, maybe you can start monitoring whether this child is going to really develop a sarcoidosis over the years.
Exactly.
Because that if so, then it will turn out to be a TAS syndrome.
Yes.
Autoimmune encephalitis, sarcoidosis, and Sjögren's syndrome. Very interesting. I think everyone has learned a lot from this webinar.
Dr. Amol is there. Just before I will.
Vinayak sir,
Okay.
Dr. Aarti Kinikar madam is there. She's HOD BJ Medical College. I would just request her to give a one or two.
Sure. I will be happy to. Will be happy to listen.
Aarti madam.
Yeah, I was listening to all these interactions, and for a moment I was thinking I was in the PICU. Okay. The students were approach also, like at their level, I think so. Rajesh has mentored them very well. And what they said that you have to have a bird's eye view. So always keep many differentials. Like, you are tempted to make a diagnosis at first shot. Like, pehle se hi ekdam fatak se aana chahiye. It's not like that in medicine. You need to know from all angles and always keep 2-3 differentials because you go and read about it. And then you realize that how to eliminate one differential. So I should thank you and the whole team and Dr. Patki who has brought out all these cases. I think many of the experts have such cases in their boxes. So they all need to come out with this. And I really like the format. Like we had a practicing pediatrician, we had the students, we had an expert who has managed these cases. So really, it's very interesting. So I should congratulate the new team for getting out a very good format of learning as well as the experienced people telling us how to go about a case. And Dr. Bhavesh sir has said about follow up the patient.
Yes.
Many times what happens is the PICU residents, once the patient is settled, they go to the ACU, step down. And then there is no connect. After that, patient gets discharged. So I feel you need to follow the patient from PICU to the wards to the discharge and also long-term follow-up, sarcoidosis and thyroid and all. So student learned today that it is not just saving a life in the PICU, but after they recover, follow them up till the end, and that's how patient relationships are developed. So it's not just exams. Don't think about 3 years and the exam you are going to pass and get it, but it's something which will remain with you lifelong. So thank you, everyone.
Thank
And
you,
it was
madam.
really amazing. Thank you.
Thank you, madam, for your comment. Yes, sir, Ram sir.
Yeah, now I request Mangai. She can give vote of
Thank you,
thanks.
sir. Thank you, sir. And I think we all definitely agree that this has been a very interesting and an enriching session. I thank our moderator, Dr. Vinayak Patki, sir, for this excellent case and for the in-depth discussion of the case. I think all of us just said that it felt as if we were in the PICU as you took us through the case. So thank you very much. And we are really eagerly waiting for all the cases to come out of your khazana, of your treasure. Thank you so much, sir. I thank our postgraduate students, Dr. Mehreen Mir and Dr. Neha Nayak, for rationally approaching this difficult case. Like all of us said, that it takes immense courage to come live and to discuss this case, which you have no clue. I think most of our practicing pediatricians who were watching this were also wishing that we were not in your position for it today. So thank you so much and congratulations. You have done a wonderful job. I would like to thank our experts, Dr. Minhaj Sheikh and Dr. Anand Bhutra, sir, for taking us stepwise through this case, dissecting the case and explaining the case to us so well, and also helping us rule out other DDs. Thank you so much, sir. It was a wonderful learning session for all of us and a wonderful innovative concept of learning with real life cases. I take this opportunity to thank Dr. Bhavesh Mithya, our President Dr. Ram Gopal sir, Dr. Vinayak Patki, and Dr. Rajesh Kulkarni for conceptualizing this academic session for us. Most of us have really enjoyed the first session and we are eagerly waiting for this series. I think our President sir has really lined up a series of wonderful activities for this year. Thank you so much, sir. I also thank our Secretary General, Dr. Amol Pawar, and the entire team, OBs and EBs of Maharashtra IIP, for their encouragement and constant support for all our activities. I thank our guest of honor, Dr. Atanu Badra, for his presence today, and Dr. Aarti ma'am for her expert views and opinions. Lastly, I thank each one of the delegate present here for this session. Thank you and good night.
Last important announcement. On 8th, we are launching one more new series that would be protocols in pediatrics.
Yes.
So 8th would be launching first episode.
Yes.
Good, good.
Okay.
8 is Friday, na, Dr.
Yeah.
Right?
I think yes.
Friday. And time is the same, 9 p.m.?
9 p.m.
So our most of the activity time is 9 p.m., right?
Right.
That's good.
Every activity would be 9. We are having almost 10 activities in a month.
Okay, great. Thanks.
Okay, thank you.
Sir.
Again, thank you very much for from my team, Ram sir, Bhavesh, very nicely been Mangala. This is a very nicely been master by you. Anand, Minaj, Rajesh, PG students. Very. I also enjoyed presenting. Your work gets when once patient improves is also one thing, and once you present and get involvement and appreciation, that's also one more important thing. This case is going to be published in we are already started in publishing this case. So maybe this will get due acknowledgement from the other scientific society also. So thank you very much all of you for being part of this first session of Casebook Live. Thank you very much.
Thank you, sir.
Thank you.
Thank
Yeah.
you. I think
Thank
it
you.
went really well. Thank you.
Yes.